We'll round things out this morning looking at plantar fasciopathy. All right. So similar to what we talked about with Achilles tendinosis, I think the first question is it fasciitis or is it fasciosis? There have been studies that have looked at doing more biopsy type things and have found that this is more of a degenerative process without the presence of inflammation. Epidemiology here, again, peak incidence between 40 and 60, so again, more often with our mature athletes. Gender studies are very much conflicting. So for every study that says that it's more common in men, there's another one that says it's more common in women. Some of the anatomic risk factors, so femoral anteversion, external malleolar torsion, which is essentially going to put you in more of a toed-out position. Pes planus or cavus foot type have been discussed, so that's not terribly helpful again. And excessive pronation. So again, we get back to the dreaded pronation, right, which, despite what you might read in Runner's World, is typically not the third leading cause of death in this country. Pronation becomes problematic when it's excessive or if it's in the wrong phase of gait, and that's a lot of the things that will happen here. Biomechanical risk factors, so limited flexibility, again, gastric soleus restrictions, BMI greater than 30, so our larger folks just from the tissue load itself, and then potentially poor footwear. So this study in JBJS in 2003, they had 50 patients all with plantar fasciopathy. The data they collected looked at ankle dorsiflexion, height, weight to get BMI, amount of workday standing, and then whether or not the subject ran. Their results, so less than or equal to 0 degrees of ankle dorsiflexion, odds ratio of 23.3, which is huge. BMI greater than 30, odds ratio of 5.6. Majority of workday on their feet, which wasn't very well defined in the study, was 3.6. So certainly comes back to one of the big things that we need to make sure we're looking at is what their ankle dorsiflexion looks like. And I think part of that is when we're lacking motion at the ankle, whether that's going to be calf flexibility or talocrural mobility, one of the more common compensatory mechanisms that our body will have is to turn the foot out slightly and typically pronate through the midfoot. So as we're collapsing as we move through our gait cycle, again, that's the pronation in the wrong phase of gait. We should set a point where we should be supinating. We're putting a whole lot more load through the plantar intrinsics as well as the plantar fascia. Okay. So how do these folks present? Again, most of us are very familiar. It's a typically insidious onset, so it just started without any clear history. Typically that first step pain in the morning is really almost diagnostic. Same type of pain after sitting for a long period of time and then getting up. Generally feel better with movement. And then pain on palpation is usually fairly exquisite right at that medial calcaneal tubercle. So if we think about treatment intervention, so gastrocsoleus stretching, so this was a study that looked at providing a medial arch support that I think can be very helpful. So again, not that I'm recommending that, but essentially not letting the foot pronate when people are stretching. I think very often when people are stretching their calf, if we allow them to turn the foot out and collapse through the midfoot, which is part of the compensatory mechanism that many of these folks already have, it may actually be contributing to make the problem worse rather than better. Foot orthoses, again, there's been countless studies in both directions as far as orthoses impacting plantar fascia, similar to the things that have been looked at for patellofemoral pain. For every study that shows that a foot orthosis can be helpful for plantar fascia, there's another one that says it's unnecessary. Again, I think there's a number of components that we need to look at rather than just you've got pain at the bottom of your foot and we're going to put something in your shoe. Plantar intrinsic strengthening, so again, thinking about the musculature that's going to support the longitudinal arch, I think can be very important as well. And then this was a review that was in JOSPT back in 2008. I want to talk about this and then some more contemporary information that, again, people I'm sure are familiar with the clinical practice guidelines that have been published in JOSPT for a number of different regional pathologies. So this is going through some of the things for plantar fasciitis. Modalities was found to have moderate evidence, so they looked at iontophoresis with both DEX or acetic acid. Provided short-term relief, so 2 to 4 weeks. Stretching, there was moderate evidence. Interestingly enough, no difference between the dosage, whether that be 20 seconds or up to 3 minutes. Taping had weak evidence. That was calcaneal taping or lodi. Again, short-term relief, 7 to 10 days. For me in clinical practice, taping is something that I'll use if somebody has has significant enough pain that they can't tolerate some of the other things that I think are important to help calm those symptoms down. Orthotic devices actually had strong evidence, but interestingly enough, there was no difference in pain reduction or improved function between prefab or custom devices. And I think that's what we're seeing more and more of now, that a lot of these folks that may benefit from an orthotic device may not need to have a custom device. They may do well with a non-custom or off-the-shelf device. Manual therapy at the time of this publication only had theoretical evidence, and they looked at both joint mobilizations as well as nerve gliding. Now, since that time, there was another study that Josh Cleland was involved in that looked at comparing two different groups. So they had electrophysical agents and exercise. That included ultrasound, ionto, stretching, and then ice, and compared that to manual physical therapy and exercise. So within that group, they had soft tissue mobilization of the calf and plantar fascia, rear foot eversion mobilizations, manual therapy to the hip, knee, ankle, and foot. And that was one component that at the therapist's discretion, if they thought there were limitations at those regions, they were allowed to address them. They taught the patient ways to mobilize the ankle into eversion, which is the bottom picture that you can see there. Also self-massage into the calf as well as the plantar fascia region. And then stretching the gastrocsoleus as well as plantar fascia. So some of the results that they found here, so comparing the two, the manual therapy to the exercise group, LEFS, 13.5 points higher at 4 weeks and almost 10 points higher at 6 months, so in favor of the manual therapy group. Foot ankle ability measure, 13% higher at 4 weeks and again 13% higher at 6 months. Pain rating scale, 1.5 points less at a month, and there was no difference at 6 months. So one of the conclusions that they had from this study, and I'll quote from this study, the combined treatment approach consisting of manual physical therapy and exercise provides greater clinical benefits in terms of function than an approach using electrophysical agents and common exercise in managing patients with plantar heel pain. So one thing that I think that this study does is talk to us a little bit about that there's going to be factors away from the site of pain that are going to be contributory. So again, people come in with pain on the bottom of their foot. I think we need to think up the kinetic chain. So again, looking at is there dysfunction at the knee, whether that's muscle imbalance or joint restriction, as well as at the hip. And thinking about things through an entire kinetic chain versus just localizing to where their symptoms are going to be. I think that part of that is because where the symptom is likely where the loads are being transferred, but I think that looking through the entire kinetic chain is going to be what helps us determine what got them there in the first place.